psoriatic arthritis. I told you something about the definition of the psoriatic arthritis or introduction to the psoriatic arthritis. And this is a very important slide. This slide also I showed you last time when I discussed about the ankylosing spondylitis. See, the prevalence of the spondyloarthritis is comparable to that of the rheumatoid arthritis. So don't think that rheumatoid arthritis is so common, but the psoriatic arthritis or spondylonegative arthritis, they are also equally common like your rheumatoid arthritis. Psoriasis affects 2% of the population. See the very big number in India, in 140 crores of the population. So 2% is a very big number. Okay. So that is the reason as a physician, you cannot avoid the psoriatic arthritis. 7 to 42% of the patients with psoriasis will develop the arthritis. See, it is not the 1% or the 2% of the psoriatic people getting the arthritis. Nearly 40%. So somewhere it starts at 7% to about 42% or 40%. See, the very high number of the people will have a psoriatic arthritis. Why I am telling all these things? As a physician, you can identify the psoriatic arthritis at an early time, so that you can start with the DMRDs and you can give good quality of the life. Otherwise, these people's quality of the life will be very, very, very poor. Psoriatic arthritis. A chronic and inflammatory arthritis in association with the skin psoriasis. Usually, rheumatoid factors or anti-CCPs or CCPs or other factors will be the negative. It is classified as one of the subtypes of the spondyloarthritis. Already I told you the synovitis, enthesitis, dactylitis, spondylitis, osteoperiosteitis, okay, or skin lesions or nail lesions, etc. See the subset of your seronegative spondyloarthritis. So ankylosing spondylitis is a sheet anchor. But whereas psoriatic arthritis can be combined with ankylosing, psoriatic arthritis can be combined with the undifferentiated, it can be combined with the reactive arthritis. So don't be happy with the single diagnosis in all the cases. See, RA plus psoriatic arthritis is also a possibility. So that fellow, the female, is having the RA for the last 20 years or 30 years. Now she is developing the psoriasis and then the psoriatic arthritis. So both the combinations will be very deadly combinations. So these things will be there in some of the individuals. So some people have the juvenile spondyloarthritis, arthritis with bowel inflammatory diseases like your ulcerative colitis or the Crohn's disease, etc. See the beautiful pictures here, the psoriatic arthritis. In the first picture, you concentrate on the hands, see the disease, see the distal interphalangeal joints, especially the right hand middle finger and the ring finger, the swollen, and see the nails of all these things, very destructive, pitting, onycholysis. And if you see the psoriatic patch on the right hand, so at the metacarpophalangeal joint, you have the psoriatic patch also. So typically, without asking any history, only on inspection alone, we can come to a reasonable diagnosis. This is a case of psoriatic arthritis. Why? The three things here. One is nail changes. The second one is distal interphalangeal joints involvement. And the third one is skin lesions, psoriatic skin lesions. And see the next picture. Foot. See that is called dactylitis. Okay. That is a sausage-shaped toes, swollen toes. So the inflammation of the flexor sheaths and also the surrounding tissues. And the third one, the skin lesion, purely a skin lesion, a psoriatic skin lesions. And then the heel, you have the enthesitis. Okay. See, these are both left heel. So that is the swollen. So that is the tendinoacheilitis or that is the enthesitis. So in this picture, you have the enthesitis, you have the dactylitis, and you have the psoriatic skin lesions, nail lesions, distal interphalangeal joints involvements, etc. So undoubtedly, this could be a case of psoriatic arthritis. Only with the inspection alone. What is the epidemiology? See the last one. The prevalence of the psoriatic arthritis is assumed to be larger than the expected. So in a country like India, where the statistics are always poor, so definitely the disease is much larger than the expected. Since enthesitis associated with psoriatic arthritis can develop without the symptoms or the signs that are recognizable by patients themselves or the physicians. What is the etiology? So mostly the genetic factors and some are the immunological mechanisms, some environmental factors. So some people are genetically prone to have the psoriasis and later the psoriatic arthritis. Trauma is a very, very important environmental factor. So this phenomenon is called as the Koebner phenomenon. The psoriatic lesions arising at the site of the trauma development of the psoriatic arthritis after trauma to the joint. So this is the Koebner's phenomenon. Some bacterial infections associated with the guttate psoriasis and streptococcal pharyngitis. Up to 30% of the psoriatic arthritis synovial tissue derived T cells proliferate following exposure to the group A streptococci. So here the streptococci could be involved in the causation of your psoriatic arthritis or your trauma, that is the Koebner's phenomenon, and those people who are genetically susceptible to have the psoriasis. This is known to occur in the families, so runs in the families. So 40% they have the family history in the first degree relative. 50 times more likely to occur in the first degree relative than the controls. And the more common in the twins also, monozygotic and the dizygotic twins. Here HLA-B27 connected with your ankylosing spondylitis in the presence of the HLA-DR7 is more in favor of the psoriatic arthritis. HLA-B22 is the protective one. So you need not remember all these things. This is only for your DM rheumatology. HLA-B27 less than the ankylosing spondylitis or the raters. Some psoriasis and spondylotic arthritis are HLA-B27 negative. Even HLA-B27 can be positive, and even in the normal individuals also. Even in the healthy individuals also it is the normal. The beauty of this slide is HLA-B27 is usually negative in psoriatic arthritis. Even it is a positive in some of the individuals. Role of the tumor necrosis, tumor necrosis TNF. It is released predominantly by cells of the monocytes and the macrophage lineage. Accumulation of the T cells, infiltration of the synovium. So they lead to the TNF mediated production of the factors that attract the C cells, monocyte chemoattractant protein 1 and macrophage inflammatory protein 3 alpha. So this is your causation or pathophysiology of your formation. Fairness we have seen in the rheumatoid arthritis. Okay. It induces the lymphocyte and the neutrophil migration into the synovium. So the cells involved mostly are the T cells and the macrophages. High levels of the tumor necrosis factor alpha will be seen in psoriatic synovium. Marked upregulation of the TNF alpha in the synovial membrane. So then it leads to the inflammation of the synovium, that synovitis, and then the enthesitis and osteitis. So the bone destruction is also seen in TNF alpha transgenic mice. They promote the release of the matrix degrading metalloproteinases. Then your pro-inflammatory cytokines like interleukins 1, 6, 8, etc. There will be the excess secretion. They cause osteoclastic bone resorption. Here you should know what you mean by the osteoclast and osteoblast. Osteoblast is new formation, new bone formation, whereas osteoclast is dying bone. So in most of the inflammatory arthritis, a chronic arthritis, even if you see a psoriatic arthritis, you have to differentiate from the rheumatoid arthritis and ankylosing spondylitis because these are the sheet diseases, are very common diseases in your inflammatory diseases. So the rheumatoid arthritis, you know, that is asymmetric, is mostly the proximal interphalangeal joints, metacarpophalangeal joints, not the distal interphalangeal joints. Distal interphalangeal joints, only two diseases. One is psoriasis, another one is osteoarthritis, your abundant spurs. So ulnar deviations, swan neck deformities, they are so common in the rheumatoid arthritis. And nodules, rheumatoid nodules, aggressive disease, rheumatoid factor usually the positive, and rheumatoid nodules people usually have the extra articular manifestations, maybe the lung involvement, maybe the liver involvement, maybe kidney involvement, etc. And the disease is very aggressive and destructive. So these are the features of the rheumatoid arthritis. See the hand. So it is not a psoriatic arthritis hand. See the nails. Have you seen any psoriatic patch here? No. Do you see any swan neck deformity of any fingers? Yes. Middle finger. Okay. So where is the involvement? It is mostly the metacarpophalangeal joints and the proximal interphalangeal joints. So that is how you have to differentiate from the psoriatic hand and the rheumatic hand. Ankylosing spondylitis. So some of the psoriatic arthritis people will also present with the spondylitis or sacroiliitis. So what is the difference between the ankylosing spondylitis and psoriatic arthritis spondylitis? HLA-B27 very common in ankylosing spondylitis. Male predominance in ankylosing spondylitis, axial involvement, sacroiliitis, your limited flexor movements at the sacroiliac joints. Your X-ray shows the bamboo spine, so that is more in favor of the ankylosing spondylitis. Kyphosis, limited motion of these joints, and Scober test, that is the limited flexion. So these are the features of your ankylosing spondylitis, and you have not seen any psoriatic patch in these cases or the nail changes in these cases. So again, a psoriasis of the sole. Some infectious agents also will cause, like Shigella, Salmonella, Yersinia, etc. So what is the classification criteria of the psoriatic arthritis? So including the 5 clinical patterns. So one is asymmetric mono or oligoarthritis, symmetric polyarthritis, distal interphalangeal joints involvement, axial involvement, that is your spondylitis and sacroiliitis, and finally destructive arthritis mutilans. And if you see here, symmetric polyarthritis is of high grade, about 15 to 65%. In the same way, oligoarthritis or asymmetric monoarthritis, it is also up to the 70%, 12 to 70%. Only the distal interphalangeal joints involvement is seen in 5% of the individuals. And only the axial involvement means your spine involvement or sacroiliac joints involvement in 5%. And whereas arthritis mutilans, very destructive disease, in about the 5%. If you see the pictures here also. Okay. The first one is large joint involvement, and the second one is the hand involvement. The third one is the typical psoriatic arthritis. So symmetric polyarthritis here. And the spine, so you have seen the syndesmophytes, osteophytes, etc. But it's not like a bamboo spine here. And the finally arthritis mutilans, and you have seen the shortening of the fingers. So the little finger is shortened in the last picture. So this is arthritis mutilans. Very little can be done at this juncture. So you have seen the patients at the 1, 2, 3 or the 4, not at the 5 stage. So this is the asymmetrical oligoarthritis, one of the 5 clinical types. This is the most common, up to 70%. Asymmetrical, similar to the low-grade gout. So here the gout is also another PD, but the gout usually involves in the metatarsophalangeal joint mostly, but sometimes polyarthritis gout is also common, not a single joint, monoarthritis. Sometimes gout may present like a polyarthritis also. I have seen one picture also when I deal with the rheumatoid arthritis. So almost looks like your rheumatoid, your subcutaneous nodules, rheumatoid nodules, but they are not the rheumatoid nodules, but the gouty nodules. Sausage-like swelling of the one or the more digits, that is a dactylitis. A large joint such as the knee is also common involved in the asymmetric oligoarticular arthritis. Less than the 5 joints are affected at any one time. Oligo means 2 to 4. 5 or more than the 5 is usually polyarthritis. Enthesitis, so that is the inflammation at the tendons, at the ligaments, or at the joint capsules. And the flexure sheath synovitis, that is your dactylitis. So these two are very important psoriatic arthritis, dactylitis and enthesitis. See, this is the dactylitis. Is a diffuse swelling of a digit. It could be acute or the chronic. Acute with the painful inflammatory changes, and a chronic wherein the digit remains the swollen despite the disappearance of the acute inflammation. So if you see such a finger, such a toes, so you are diagnosed with dactylitis. Once you are thinking of dactylitis, you should think about the psoriasis also. So along with the dactylitis, if you identify the enthesitis, and definitely your diagnosis is psoriatic arthritis. See the beauty of the rheumatology. So here you should understand the pathology, you should understand some of these diseases and see and diagnose it. That's all. Investigations mostly to exclude or to include 1 or 2 points. 90 to 95% would diagnose with the history alone in rheumatology. So they also refer to as the sausage disease, recognized as one of the cardinal features of the psoriatic arthritis, occurring in up to 40% of the patients. Feet most commonly affected. So here this is the feet, this is the toes. Dactylitis involved disease show more radiographic damage. If you take an X-ray here, so the more of the changes, radiological changes will be clearly seen in those sausage digits or the dactylitis digits. See the fingers also, see the nails also here. So there will be the pits also there. Nail pitting is also seen on the great toe. So this is the enthesitis. Is the regions at which a tendon, a ligament, or a joint capsule attaches to the bone. Inflammation at the enthesis is called the enthesitis and is the hallmark feature of the psoriatic arthritis along with your dactylitis. So dactylitis and enthesitis, these two are the cardinal features of the psoriatic arthritis. So pathogenesis yet to be fully elucidated. Isolated peripheral enthesitis may be the only rheumatological sign of psoriatic arthritis in a subset of the patients. So if you identify the psoriasis at this juncture, so you are a very, very good clinician. So don't think that in all the psoriatic arthritis, psoriasis comes first and the arthritis next. Anyone can diagnose with a psoriatic patch and some arthritis. But some people, in 20% of the population, arthritis comes first, later the psoriasis. Here, your physician's knowledge should help the patient to diagnose the psoriatic arthritis much before the psoriatic patch appears. So this is the symmetrical polyarthritis. Almost looks like your rheumatoid arthritis, but here see the distal interphalangeal joints. So the distal interphalangeal joints, all the distal interphalangeal joints are swollen, they are very reddish and they are then inflamed. Okay, so this is the point of your psoriatic arthritis when compared to the rheumatoid arthritis. Rheumatoid-like pattern. 15% is the symmetrical polyarthritis. Hands, wrist, ankles, and the feet may be involved. Most needy rheumatoid arthritis by the distal interphalangeal joints involvement in psoriatic. Morning stiffness will be there, but very, very high in rheumatoid arthritis when compared to the psoriatic arthritis. The fusiform deformity or the sausage disease are very common in psoriasis. Windswept deformity, relatively asymmetry, subcutaneous nodules usually absent. They are positive in rheumatoid arthritis, absent in psoriatic. Rheumatoid factor or anti-CCP, etc. Here the negative in psoriatic and milder with a less deformity in psoriatic arthritis. Okay, so that is how you differentiate the hand of the rheumatoid hand from your psoriatic hand. So the distal interphalangeal arthropathy is the classical form, but unfortunately not that common. So less common in about 16%. Involvement of the nail with the significant inflammation of the paronychia and swelling of the distal tuft may be the prominent. 30 pits with inflammatory arthritis of the distal interphalangeal joints consider the diagnostic. So if you count the pits and the nail, so the more than the 30 pits will be there in the nails along with the distal interphalangeal joints involvement. So most probably your diagnosis is psoriatic arthritis, but we never count it. But obviously you can see the nails in the psoriatic arthritis. Only with experience you can identify the psoriatic nails. See the distal interphalangeal joints here in the X-ray changes. So this is the very deadly form, arthritis mutilans. Fortunately, it's a very rare, 1 to 5%. Some reports suggest up to 16% of the patients. Resorption of the bone, that is osteolysis. That is the digit will be the slow, will be short in size. With the dissolution of the joint is observed as the pencil in the cup. Radiographic finding, that is a classical finding. Pencil in the cup finding is so common in psoriatic arthritis and leads to the redundant overlying skin with a telescoping motion of the digit. The opera glass hand is males more than the females and is more frequent in the early onset disease. So opera glass hand and the penicillin cup. So these two features for the radiologist point of view. See here. So this is the arthritis mutilans. A typically psoriatic patient pattern of the arthritis, which is associated with the characteristic penicillin cup radiographic appearance. See here, mostly the thumb. You can identify the penicillin cup. X-ray, a thumb. Okay. And see the distal interphalangeal joints. Almost a fusion. Limited range of the movements. Narrowed interjoint space. So this is the arthritis mutilans. Now coming to the axial skeleton. So we have discussed something about the hand, feet, enthesitis, dactylitis. Now move on to the spondylitis. 5% of the patients and has a male predominance can occur in conjunction with other subgroups of the psoriatic arthritis. So usually the spondylitis or the sacroiliitis, even though the psoriatic arthritis is punished one, but these spondylitis and sacroiliitis are more common in the males when compared to the female psoriatic arthritis individuals. Without the radiographic evidence of the sacroiliitis, which frequently tends to be asymmetrical, may appear radiologically without the classic symptoms of the morning stiffness in the lower back. Correlation between symptoms and the radiological sense of sacroiliitis can be poor, and vertebral involvement differs from that observed in the ankylosing spondylitis. So ankylosing spondylitis, I have shown you the bamboo spine pictures like that. So the such type of the pictures we won't see in psoriatic arthritis. So this is not that common when compared to the ankylosing spondylitis. The involvement is also not that common. So this is something about your spondylitis and sacroiliitis. So here the people will have a low backache. The people will have the lower flexion deformities of the sacroiliac joints. So difficulty in walking, difficulty in getting up from the sitting position. So all these things will be seen in this population. See the vertebrae here. They are affected asymmetrically, and the atlantoaxial joint may be involved with the erosion of the odontoid and subluxation. Therapy may limit the subluxation associated disability. Unusual radiological feature, non-marginal asymmetrical syndesmopides. That is a very characteristic. Paravertebral ossification and vertebral fusion with the disc calcification. But we don't see such things in our routine patients. Very rare, very rare. So this is an important slide. Shows you the patterns may change over the time. So in 2015, the patient presents like oligoarthritis. Maybe in 2020, polyarthritis. In 2025, maybe the arthritis mutilans. So it's always a progressive and the dynamic disease. So the patterns may change over the time. Suppose if you give a good DMRDs, or if you start with the biologicals, obviously the disease also may reduce in its incidence and also may change and may have a mild disease. On the other hand, this mild disease will become the very major disease. See the clinical subgroups at the baseline and the follow-up. Suppose you presents with your monoarthritis. If you are treating a case of psoriatic monoarthritis, so two things will happen. Either the monoarthritis with your good treatment and then disappearance of the monoarthritis, or no clinical evidence of the joint disease at all. Okay. And in oligoarthritis, so they come back to the joints reduction, that is the monoarthritis. Oligoarthritis means 2 to 4, or it may become a polyarthritis, or no clinical evidence of the joint disease with your beautiful management. The same thing, distal interphalangeal joints, or polyarthritis, spondyloarthritis, arthritis mutilans. So all these things are very common in psoriatic arthritis, from one thing to another change. But with your effective treatment, no clinical evidence of the joint disease also could be a possible. So we all should aim for no clinical evidence of the joint disease. So this is the criteria for the classification. The name given to this is Caspar. Inflammatory articular disease. Here see the joint, you see the spine, and see the enthesis. With more than the 3 points from the following categories. Suppose if the psoriasis, a current psoriasis, psoriatic patch, etc., 2 points. History of the psoriasis, 1 point. Even if there is no current psoriasis or no history, if the family history is there, give 1 point. See the nails. Nail dystrophy, you take 1 point. And rheumatoid factor negativity, again 1 point. Dactylitis, current history are recorded by a rheumatologist or a physician. Radiographs, evidence of the just articular newborn formation. And with this criteria, this Caspar criteria, so you have the specificity nearly the 99% and sensitivity nearly 91%. So that's how you have to see the psoriatic arthritis individuals. So psoriatic arthritis means not only the skin and the nails, but also the distal interphalangeal joints, but also the spine and also the sacroiliac joints, etc. So here the morning stiffness lasting more than 30 minutes in about the 15% of the patients. Some people may have the morning stiffness of more than 1 hour, more than the 2 hours. Ridging, pitting of the nails, onycholysis up to 90% of the patients versus the nail changes in only 40% of the psoriasis cases. Patients may present with a less joint tenderness than is usually seen in rheumatoid arthritis. In rheumatoid arthritis, joint tenderness is very high. Just if you touch the metacarpophalangeal joints or the proximal interphalangeal joints, they are very, very tender. But whereas psoriatic arthritis joints, they are not that tender when compared to the rheumatoid arthritis. Dactylitis may be noted in more than 40% of the cases, the unique of your psoriatic arthritis. And most important is the eye inflammation. Your iridocyclitis or your uveitis, etc. are very common in psoriatic arthritis, like your ankylosing spondylitis. See, 7 to 33% of the cases, uveitis show a greater tendency to a bilateral and a chronic when compared to the ankylosing spondylitis. So here, eye inflammation means not only the conjunctivitis, iritis, and also uveitis. Distal extremity swelling with the pitting edema has been reported in 20% of the patients as the first isolated manifestation of psoriatic arthritis. Sometimes it could be the only presentation, distal extremity swelling with the pitting edema. So most of the times, if you see the pitting edema in the feet or in the legs, so your diagnosis could be heart failure, it could be nephrotic syndrome, or could be cirrhosis of the liver, it could be a gross anemia, hypoproteinemia, etc. In some cases, it could be psoriatic arthritis early stages. So this is a very important slide, shows you the clinical psoriasis, the skin and the nails, peripheral arthritis, distal involvement, dactylitis and enthesitis. And the laboratory, the negative rheumatoid factor, negative CCP, etc. And elevated acute phase like your CRP or the ESR, depends on the inflammation and the infection. Radiographic, you have the erosions and the resorptions, osteoclasts, joint space narrowing or involvement of the enthesitis, newborn growth at the enthesitis, spondylitis, sacroiliitis, and syndesmophytes. So these are the common in your skeletal, axial skeleton. So the main features and their frequency. See the back involvement, spinal cord involvement in 50%, more in the males. Your dactylitis nearly 48%. Your distal infernal joints nearly 40%. Nail changes especially 80%, and enthesopathy nearly 40%. So these are the main features of your psoriatic arthritis. See the comorbidities. So ocular inflammation. So that is your already I discussed about the eye involvement. So all the people with the psoriatic arthritis, when they have the gritty sensation in the eyes or the redness of the eyes or watering of the eyes, so immediately we have to refer them to a ophthalmologist to rule out these changes. And you write it on the letter that this is a known patient of psoriasis, psoriatic arthritis, getting DMRDs, etc., etc. Please look for uveitis. Please look for iridocyclitis. Please look for any autoimmune involvement in the eyes. So then the doctor will look at. Otherwise, they do. So they check the refraction and then they send the patient. So use the same glasses. Okay, you don't require any glasses. So that is not we require. So what we want is to rule out your iridocyclitis, to rule out your uveitis, etc. So this should be very clear in writing to the letter to the ophthalmologist what you are thinking of. See the IBD. So unfortunately, these are very common in our India. So earlier, ulcerative colitis and Crohn's disease were not that common in Indian population. But now because of the pizzas and other Western diet, now the IBD is also so common in Indian population. So the nail pitting, transverse depressions and subungual hyperkeratosis. See the metabolic syndrome, comorbidity in psoriasis. So metabolic syndrome means totally a physician's disease. So your diabetes, your hypertension, etc., etc. See the psoriatic patient, psychosocial burden. So physicians means a lot of the people will have the psychosocial burden. They are all chronic diseases. Depression is so common. Reactive depression. Okay. Higher suicidal tendencies. Alcoholism, smoking, gutka, ganjai, drugs. So these are so common in any chronic illness people. So the psoriatic arthritis is also not an exemption because the skin is not good, their nails are not good, and they are suffering with a lot of the arthritis. So there is no meaning in continuing the life. In such way, they go for the suicidal tendencies also. So these are very common. So when you are dealing a case of the psoriatic arthritis as a physician, so you have to read the mind of the particular person also. Mind is different from your brain or the body. So the mind is also important. So otherwise these people will go into the psychiatric abnormalities. So comorbidities in the psoriatic arthritis, not only your joints, your skin and etc. etc. So please look up the psychosocial aspects and also the metabolic syndrome and the inflammatory bowel diseases and the ophthalmological involvement. So then only you are a true physician. So stage the psoriatic arthritis, mild, moderate and the severe. The peripheral arthritis, so less number, mild, middle number, so moderate, very high number, severe. Skin disease. So what you mean by the BSA? That is the body surface area. What you mean by PASI? PASI psoriasis area severity index. So low, that is a mild disease. Very high, severe disease. Midway, it is a moderate. So to differentiate the psoriasis into mild, moderate, severe, see the peripheral arthritis, see the skin disease, see the spine, see the enthesitis, see the dactylitis. When in the low in the number, your disease is mild. When they are very high in number, that is a very severe. At middle numbers, you have a moderate disease. So by classifying or to stage, you have to concentrate on these 5 findings: arthritis findings, skin findings, spine involvement, your enthesitis, and dactylitis. So now coming to the treatment of the psoriatic arthritis. See, the patient education is very important in all the chronic diseases. So medical education, physical and occupational therapy, your physiotherapist so plays a major role in rheumatology practice. Pharmacological interventions, not only your NSAIDs or the steroids and DMRTs and biologicals. And finally, some people sometimes reconstructive surgery and the rehabilitation. So these are the common drugs we use. NSAIDs of your choice, almost individualized. So you have the aspirin, you have the ibuprofen, you have the paracetamol, you have the indomethacin, you have the aceclofenac, okay, the ketorolac, diclofenac, etc. And then the DMRTs, anti-malarials, hydroxychloroquine. Gold we are not using right now. Sulfasalazine is a very good drug. Methotrexate is a wonderful drug. And oral retinoids, immunosuppressants like cyclosporin, corticosteroids, azathioprine, cytokine blockers like your tumor necrosis factor alpha blockers or CD20 blockers like etanercept, infliximab, adalimumab, etc. And others includes the surgical involvement or the physiotherapy. So this slide shows you the different modalities we have to prescribe in our psoriatic arthritis. So don't be happy with the NSAIDs alone. So you have to start with the DMRTs and immunosuppressant in some individuals. Mostly you have to take the help of the steroids as a bridge therapy and cytokine blockers when the disease is very aggressive, very severe with arthritis mutilans, etc. So these are the dosing schedules, monitoring and the side effects of your DMRTs. Last class I discussed about the methotrexate. So thanks to Yalapragad Subbarao garu, who started with 5 mg or 7.5 mg or 10 mg, 15 mg, 20 mg, even the 25 mg. So once in a week as a pulse therapy. Always use folic acid supplementation along with your methotrexate. So monitor the complete blood counts because they causes the immunosuppression, they cause the bone suppression, bone marrow suppression. So the CBP is very important here. They are hepatotoxic drugs. So get the LFT. They are the rhinotoxic drugs. So get the RFT. So the CBP, RFT and LFT at least once in 3 months or once in 4 months. So that's how you have to monitor the dosage of your methotrexate. And then you have to wait for at least 2 to 3 months after starting the methotrexate to have a therapeutic effect. So meanwhile, you can use the steroids as a bridge therapy. Later, after 2 months or 3 months, slowly you have to taper the doses of your steroids. Side effects, you have the nausea, fatigue, mouth ulcers, mucositis, and elevated LFTs. And then you have to reduce the dose of the methotrexate when the patient gets the side effects, or you have to stop it. And prolonged usage of the methotrexate may cause dyspnea, etc. So that is called methotrexate lung. So where again you have to identify whether it is methotrexate lung or ILD by getting a CT chest and then act accordingly. If it is a methotrexate lung, stop using the methotrexate. If it is ILD, start using methylprednisolone or other azathioprine, etc. Sulfasalazine, we start with 500 milligrams OD and slowly you have to go to 500 milligrams BD in the next week, and then the 500 milligrams T8 in the next week, third week, and then the 1000 milligrams BD. That is the maximum dose is 2 grams per day. Every day is the salzopyrin. Again, here the CBP con LFT and azoospermia. So this is the very, very common side effect of your salzopyrin. Okay, reduce sperm count. So infertility is so common on those people who are using the sulfasalazine. Leflunomide is a very good drug. You have to use it every day. So in the earlier we used to give the loading dose of 100 milligrams, but now we are not giving the loading dose 10 milligrams or 20 milligrams every day. Again, it causes the bone marrow suppression. So CBP, your LFT, RFT as usual, once in 3 months, should not be used in the young females of the childbearing age. So in pregnancy, in the lactation, 2 drugs are contraindicated, the methotrexate and leflunomide. And pregnancy and the lactation in other situations, the safest drugs are the steroids and sulfasalazine and hydroxychloroquine. Hydroxychloroquine and sulfasalazine are the safe, whereas the methotrexate and leflunomide has to be stopped. Hydroxychloroquine eye examination, but fortunately, when compared to the simple chloroquine, the eye involvement with hydroxychloroquine is not that high when compared to the chloroquine. But anyhow, at least once in a year, eye examination must be done on people who are on hydroxychloroquine. We start with 200 milligrams, 300 mg is available, 400 mg is also available. So 200 to 400 mg is the dosage. Cyclosporin we don't use as the initial agent of the choice, but we use it in the resistant cases. But the two things are very important on the cyclosporin. It may cause renal abnormalities or it may raise your blood pressure. So the hypertension caused by the cyclosporin is so common. In the same way, elevated your urea creatinine levels also common with the cyclosporin levels. So you have to act accordingly. Methylprednisolone is a beautiful drug. We use it as a 500 mg or 250 mg or 1000. That's the 1 gram once a day for 3 days or the 5 days when the patient is in vasculitis, when the patient is in flares, when the disease is very, very aggressive. We use the methylprednisolone. Otherwise, we don't. We use simple prednisolone or your visolone otherwise. Prednisolone is a good drug, but you know the side effects of these steroids. So they cause diabetes, they cause hypertension, they cause obesity, they cause osteoporosis, especially the postmenopausal women. So always use high doses of the calcium when the fellow is on steroid therapy. Otherwise, fractures, bone fractures, vertebral fractures, so common. So this slide I showed you last week. So what are all the changes here? See the nascias, how they act. In the psoriasis, in the nail changes, peripheral arthritis, spondylitis. So the nascias, they don't act on the nail, they don't act on the skin changes, they act on the peripheral arthritis and spondylitis. Those people with the peripheral arthritis, spondylitis, they may better with nascias. That is for the short time only. But otherwise, if you use the nascias for a longer period, again they cause gastropathy, they cause renal defects, they cause hepatotoxicity, etc. So the methotrexate, beautiful drug. See, they act on the psoriatic skin lesions. There is the psoriatic nail lesions. They also on the peripheral arthritis. Okay. So they may also act on the extraarticular features like the uveitis, etc. So that is the reason methotrexate is a good drug. Is the sheet anchor in most of the inflammatory diseases because they're not only acting on the joints alone, so they also have the extra joint advantages. Leflunomide, the same thing here. Biological agents, see, all biological agents will act. So biological agents will act on the psoriatic skin patches, on the nail diseases, peripheral arthritis, spondylitis, enthesitis, dactylitis, and also uveitis, etc. Suppose if the patient can afford in an aggressive psoriatic patient with all these features, I think the best drug to be started on the day one is your biologicals. Maybe your adalimumab, maybe your infliximab or rituximab or etc. Other etanercept, etc. These are common biologicals we often use in our routine practice as initial agents of the choice or the sheet anchors in the management of the psoriatic arthritis. Indications for the biological agents. Psoriasis, extensive psoriasis, not responding to your phototherapy, retinoids, methotrexate, cyclosporin. So you are using the methotrexate, you are using the phototherapy, you are using the other agents, but any extensive psoriatic patches all over the body. So definitely there is indication for the biologicals. Nail changes. To local and the traditional, no relation. Not responded to the local and the traditional systemic retinoids, methotrexate and cyclosporin. Nail changes. Again, they respond very well to your biologicals. In peripheral arthritis, no response to your nascias, intra-articular injections or traditional DMRTs. Again, go for the biologicals. Spondylitis, no response to your nasciad therapy. Enthesitis, no response to your nasciads and local cortisol injections. Dactylitis, again, no response to your nasciads or DMRTs or local cortisone injections or extra-articular features. In all these features, biologicals are very, very, very important. So as a physician, you should know when to use the biologicals, where to use the biologicals, and which type of the biologicals we are supposed to prescribe them. Even though they are little costly at this juncture, but they give a lot of the benefit to the patients because they act on all these parameters, which are very, very important to give a good quality of the life. Suppose any psoriatic arthritis fellow with all these features, If they want the quality of the life, I think the best drug to be started is always a biological one. So these are the different dosages. So we use infliximab, we use etanercept, we use adalimumab and the rituximab. See, adalimumab is my favorite drug. It's available as a 40 mg once every 2 weeks. So once in a week or once in 15 days, we use the adalimumab. It is available at the cost of 30,000 rupees, but fortunately we are getting at cost of 7 to 8,000 rupees. So give one shot once in 15 days or once in a month, so the people will get tremendous response. That is the adalimumab subcutaneous. And any of these biologicals, before you start with the biologicals, 3 investigations are very, very important. Last time also I told you, Manto, quantiferon gold and CT chest. Okay, so the Manto, quantiferon gold and the CT chest to rule out the latent tuberculosis. Otherwise, if you start these biologicals, so these latent tuberculosis will become very active. So that is the only suggestion, not to start the biologicals on the day one. So even though the patient can afford to have the biological therapy, before you start the biological therapy, you should get all these 3 investigations: Manto, quantiferon gold, and then the CT abdomen. So these are the important injections. So these are all the drugs useful: methotrexate, sulfasalazine, leflunomide, apremilast. So that is a very important drug. Nowadays the dermatologists are using extensively the apremilast 30 milligrams twice daily, very useful in the skin lesions also. And other things I already told you. And now we are using the tofacitinib, so JAK inhibitor. So tofacitinib, that is as well, it is very useful in your extensive rheumatoid arthritis and also in your psoriatic arthritis. See what are the treatment options. Peripheral arthritis. Suppose the patient is having the peripheral arthritis. What are your options? You can give the NSAIDs because they are the painkillers. You can give the intra-articular injections, suppose the 1 or 2 joints. You can start with the DMRDs like with methotrexate, etc. And also you can give the apremilast biologicals. Suppose they also act on the psoriatic skin lesions, 30 milligrams twice a day or once a day, and JAK inhibitors. Suppose if the patient is having the skin and the nail disease only, skin and nail diseases, a purely a dermatological disease. So you can give the topical steroids, your phototherapy, your ultraviolet rays, your methotrexate, leflunomide, and apremilast. See the biologicals. So biologicals also acts on the skin and the nail disease. Not only the arthritis reduction, the pure dermatological problems like your psoriatic skin or the nail changes, the psoriasis can also be reduced with your biologicals. Axial disease, so that is your spinal involvement. See the NSAIDs, your physiotherapy, biologicals, and JAK inhibitors. Dactylitis and enthesitis, the same thing. So what are the bacteria associated with your reactive arthritis? So some of the people, psoriatic arthritis, so they may come up with a reactive arthritis. So some bacteria like your Salmonella, Shigella, Yersinia, etc. Some urogenital, chlamydia, respiratory infections. So they present like the reactive arthritis. You know that, no? Following your short viral fever or following your gastroenteritis, these people will present with a lot of the joints, polyarthritis, almost like your chikungunya fever. So a lot of the joints, polyarthritis at a very rapid onset. So that is your reactive arthritis. So I think the poor slide, quality of the slide is not good, but it shows a comparison of the different spondyloarthritis. So your ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and your intestinal arthritis, that is enteropathic arthritis. See the psoriatic arthritis, gender 1:1, age of the onset 35 to 55, sacroiliitis of spondylitis about 20%, symmetry of the sacroiliitis is symmetry, peripheral arthritis frequency is about 95% peripheral arthritis, distribution, your oligo or poly, the affected joints, you know that, uveitis 20% of the patients, dactylitis about 50%, skin or nail changes, yes, psoriatic skin, nail pitting, onycholysis, HLA-B27 could be positive in about 25%. Radiology, unilateral, asymmetric, and bulky. So these are the features of your psoriatic arthritis. So other agents are also there. Surgical care, in arthroscopic synovectomy has been effective in treating the severe chronic and monoarticular synovitis. Joint replacements and forms of the reconstructive therapy. So hip joint replacement, knee joint replacement, or your shoulder joint replacement, they all can. So hip and knee successful. Monitoring, yes. Dietary consultation, good diet. Physiotherapy is very important. Should be individualized and should be started early in the disease process. Such a program should consider the use of the following: rest, local and the systemic, some exercises, some modalities, heat and the cold, some orthotics. So all these people, our physiotherapy people will take care of all these things. Prevention, lithium and withdrawal from the systemic steroids are well known to cause the disease flare-ups. Other drugs that have been implicated include the beta blockers, anti-malarials, etc. If skin lesions worsen with an NSAID, switch to the different family of the NSAID. Prevention includes rest and exercise. Joint protection, splints, braces, and other supports may be helpful. No definitive prevention exists because this is a chronic disease that can wax and wane. See that this is the arthritis mutilans. So penicillin cup. See the destructions, joint destructions. So stop staring, start caring. Psoriasis is not a contagious one. So thank you very much.